Welcome back to the deep dive. Today, we're opening up a file that feels less like a standard medical review and honestly more like a biological thriller. We're looking at the hidden killers of the hospital ward. We're talking about fungi.
A really important topic.
And we are basing this entire discussion on two absolute heavyweights in the field. Chapter 61 of Goodman and Gilman and Chapter 48 of Katzung.
It's a fascinating, and you said it, a slightly terrifying topic. When you really dig into the pharmacology here, you realize we're walking a very, very thin line.
It really is. And I think for most of us, even those in the medical field, when we think antimicrobials, our brains just default to antibiotics, right?
Yes, bacteria.
We think about killing bacteria. We have 100 ways to kill bacteria. But today we are looking at a completely different beast. And the outline starts us off with this concept, the near-neighbor paradox.
Yeah.
It sounds like a sci-fi novel title, but it's actually the central tension of this entire field. What exactly are we dealing with here?
So this is the fundamental problem. This is why antifungal therapy is so much harder.
Yeah.
And frankly, more dangerous than antibacterial therapy.
Okay.
If you look at a bacterium under a microscope, say E. coli, it's a prokaryote. It's an alien, biologically speaking.
Right. Different operating system completely.
Totally different. Its DNA is organized differently. It has a cell wall made of peptidoglycan, which we don't have. Its ribosomes are different sizes. It's relatively easy to design a weapon like penicillin that blows up the alien but leaves the human cell completely untouched.
That's the classic definition of selective toxicity. You want a magic bullet that hits the target and misses the bystander.
Exactly. High selective toxicity. That's the goal.
Right.
But a fungus is a eukaryote.
Just like us.
Just like us. If you zoom in on a fungal cell, it looks shockingly similar to a human cell. It has a nucleus with a membrane, just like ours. It has mitochondria, its DNA structure, its protein synthesis machinery. It's all nearly identical to ours. We are, essentially cousins on the evolutionary tree.
So targeting a fungus is much harder because you're essentially trying to shoot a bad guy who is wearing the exact same uniform as the hostage.
That is the perfect analogy.
Yeah.
It is not about carpet bombing anymore. Not at all. It's about finding the tiniest, most subtle differences, a slightly different lipid in the membrane, a layer of armor we don't have, and exploiting that difference to kill the fungus without poisoning the patient.
And we're going to see that's a recurring theme.
Oh, absolutely.
Right.
As we go through these drugs, you'll see that the margin for error is razor thin. We are operating in the margins of biology.
And the stakes are getting higher. The sources mention that while there are, over 1 million species of fungi out there, only about 400 really cause human disease.
Something like that, yeah.
But those 400 are becoming a major problem.
They are. And we really need to contextualize why this is happening now. Historically, fungal infections were, kind of rare and usually superficial. Think athlete's foot or thrush.
Annoying, but not usually deadly.
Annoying, but not lethal.
Right.
But in modern medicine, we have inadvertently created a new vulnerability. Fungi are what we call opportunistic pathogens.
They wait for an opening.
The ultimate opportunists. I love the metaphor in the outline. They're the dark matter of the hospital. They're always there, spores floating in the air, candida living in our gut. But our immune system keeps them in check, just effortlessly.
Not until the lights go out.
Exactly. When the immune system is suppressed, whether that's due to HIV/AIDS or because we're giving powerful chemotherapy for cancer or immunosuppressants for organ transplants, that invisible dark matter suddenly becomes a visible, life-threatening infection. As we've gotten better at keeping vulnerable people alive, we've inadvertently created a playground for invasive mycosis.
That's a sobering thought. Our medical advancements have invited a new enemy to the table. So let's map out how we fight back. The roadmap for this deep dive is structured around the 3 main battlefields where we engage these eukaryotic invaders. First, the cell membrane. We'll call that the wall. Second, the cell wall. That's the armor. And third, the nucleus, the command center.
A great way to structure it. And just a quick disclaimer before we dive in. This discussion is a conceptual synthesis. We're pulling the key insights from Katzung and Goodman and Gilman to give you a mental map of the pharmacology.
Right, a framework.
A framework. But details matter. Doses matter. Clinical context matters. So consider this the scaffolding. You still need to read the chapters to fill in the bricks. This is not a substitute.
Absolutely. Okay, let's start with battlefield number 1, the cell membrane. This seems to be where the oldest and, I guess, most famous drugs operate.
The membrane is the classic target. It's the original battlefield. Now, remember the paradox.
We're both eukaryotes?
Right. Human cells and fungal cells both have cell membranes made of a lipid bilayer. So if you just attack the membrane indiscriminately, like, say, using a detergent, you dissolve the fungus, but you also dissolve the human patient. Not a good outcome.
So what's the difference? What's the Achilles heel?
It comes down to one specific molecule, a single crucial difference. In human cell membranes, the primary sterol, that's the molecule that acts like the mortar between the lipid bricks, giving the membrane stability and fluidity, is cholesterol.
Okay, cholesterol. We know that one. Usually we're trying to get rid of it, but here it's keeping us together.
Right. It's absolutely essential for cell integrity. But fungi, for whatever evolutionary reason, do not use cholesterol. They use a very similar near-neighbor molecule called ergosterol.
Ergosterol.
Ergosterol. It's a subtle difference in chemical structure. I mean, just a few double bonds in a methyl group, different, but it's enough. That slight difference is the target for our heavy artillery.
And when you say heavy artillery, I'm guessing you are talking about the legend, the gold standard, amphotericin B.
The one and only, AMPHO. It was discovered back in the 1950s from a bacteria called Streptomyces nodosus, found in the soil of the Orinoco River Valley in Venezuela, of all places.
Wow.
And despite being over 60 years old, it is still the broadest spectrum antifungal agent we have. It kills yeast, it kills mold, it kills almost everything.
I've heard it called the sledgehammer.
That is a very, very fair description. It is unsubtle, it is powerful, and it destroys things.
So how does the sledgehammer actually work?
Well, this is where it gets really interesting because our two sources actually give us a slightly evolving view of this. The classic teaching, which you'll find in Katsung and most older textbooks, is the pore model.
Okay, walk me through the pore model.
Amphotericin B is a large rod-shaped molecule. It's what we call a polyene macrolide. And it's amphipathic, meaning one side of the rod loves fat, it's lipophilic, and the other side loves water hydrophilic. The theory is that the drug inserts itself into the fungal membrane, binding specifically to ergosterol. It then clusters together with other ampho molecules to form a ring, a literal pore or hole in the membrane.
So it punches a hole in the wall.
Exactly. Imagine a barrel made of drug molecules just stuck right into the membrane. The inside of that barrel is hydrophilic water-loving, so it allows water and ions to just rush right through.
And that's bad for the fungus.
It's lethal. The fungal cell works very hard to keep potassium inside at high concentrations. Once you punch these holes, the potassium leaks out, sodium rushes in, the electrical potential of the cell collapses, and the fungus effectively bleeds out and dies. It is fungicidal. It kills.
Simple, brutal, effective. But Goodman and Gilman introduces a new twist on this, right? A different model.
They do. And this is why I love digging into the mechanisms.
Yeah.
Recent research suggests it might not just be about holes. They call it the sponge model.
The sponge model. That sounds a lot less aggressive than a sledgehammer punching holes.
It sounds softer, but the effect is just as devastating. The idea is that amphotericin B forms these large aggregates, these clumps, on the surface of the membrane that act like a sponge.
A sponge for what?
For ergosterol. They literally suck the ergosterol right out of the lipid bilayer. It physically sequesters the ergosterol.
Wait, so it's not just poking a hole, it's ripping the structural beams out of the building.
Essentially, yes. By extracting the ergosterol, the mortar between the bricks, the entire membrane structure fails and collapses. So whether it's a pore letting things leak out or a sponge pulling the wall apart, the result is the same. The membrane is destroyed and the fungus dies.
That sounds incredibly effective, but if it's so effective, why don't we use it for everything? Why isn't it the Tylenol of antifungals?
Because of the near-neighbor problem we started with, amphotericin B prefers ergosterol. It binds to it with much higher affinity, maybe 500 times higher, but
But it also binds to cholesterol.
it also binds to our cholesterol, just not as tightly.
Yeah.
But it does bind.
Ah, so it hits human cells, too. The sledgehammer isn't that precise.
It's not. And that brings us to the toxicity. In the hospital, amphotericin B has a very notorious nickname, amphoterrible.
Amphoterrible. That does not sound like a drug you want to be on.
No. The toxicity comes in two waves. First, you have the immediate infusion reaction. We call it the shake and bake.
Shake and bake? That sounds almost jaunty, but I have a feeling it's not.
It is absolutely miserable for the patient. Within 1 to 3 hours of starting the IV, the patient develops violent rigors, shaking chills, high fever, vomiting, muscle spasms, headache, hypotension. It's like a massive, induced cytokine storm.
What is physically happening there? Is that the drug attacking our cells directly?
It's actually an immune storm. The presence of the drug in our system triggers our immune cells, our macrophages, to release a flood of pro-inflammatory cytokines, tumor necrosis factor alpha, or TNF-alpha, and interleukin-1. The body thinks it's under a massive attack.
So it's our own body's reaction to the drug.
Precisely. We often have to pre-medicate patients with antihistamines, Tylenol, sometimes even corticosteroids, just to get the drug into them without them shaking the bed apart.
That sounds just awful, and that's only the immediate reaction.
Right, that's wave one. The second wave is the slow, cumulative damage to the kidneys. Amphotericin is notoriously nephrotoxic.
It hurts the kidneys.
It hits the kidney in a double whammy. First, it causes vasoconstriction of the afferent arterioles, the little blood vessels that feed the kidney's filtration units, the glomeruli. So it chokes off the blood supply.
Ischemic injury. It's strangling the kidney.
Correct. And second, the drug itself gets filtered and binds to the cholesterol in our own renal tubular cells, punching holes in them, just like it does to the fungus. So you have a starving kidney that is also being chemically burned.
What does that do to the patient?
It causes something called renal tubular acidosis. Patients lose massive amounts of potassium and magnesium in their urine. You have to constantly check their labs and replace their electrolytes, or their heart can develop a fetal arrhythmia.
It also causes anemia, doesn't it? I remember reading that in Katsung.
Yes, because the damaged kidneys stop making erythropoietin, or EPO, which is the hormone that tells the bone marrow to make new red blood cells. So long-term AMPHO use almost guarantees kidney damage and anemia.
So we have a drug that is incredibly powerful against the fungus, but is actively hurting the patient's kidneys and making them feel terrible.
Yeah.
How have we solved this? Or have we?
We have innovated. This is actually one of the coolest applications of drug delivery systems in all of pharmacology. We realized the toxicity comes from the free drug floating in the blood and bumping into human cells.
Okay.
So scientists developed lipid formulations.
Is this the liposomal amphotericin I see in the patient charts? Ambisome.
Exactly. Think of it as a Trojan horse, or maybe better yet, a lifeboat. They packaged the amphotericin B molecule inside tiny spheres made of lipids.
So it's hidden.
When this lipid sphere is traveling through the human bloodstream, the drug stays safely inside the lifeboat. It's sequestered. It doesn't interact as much with the human kidney cells or the immune cells.
So it's shielded from the patient.
Right. But, and here's the clever part, when the sphere encounters a fungus or fungal lipases, which are enzymes that break down fat at the site of infection, the drug is released. Or, simply because the drug has such a high affinity for ergosterol, when the liposome bumps into a fungal cell, the drug just jumps ship.
Wow. So it's like a targeted delivery system. The drug only gets out of the lifeboat when it sees the enemy ship.
It dramatically reduces the toxicity. The efficacy is about the same, but the safety profile is much, much better. You see far less kidney failure and much less of that shake and bake.
So why do we still use the old amphoterrible version, the deoxycholate formulation?
Cost. Pure and simple. The lipid formulations are significantly more expensive to manufacture. In resource-limited settings, the old deoxychol formulation is still the workhorse. But in modern Western hospitals, especially for patients who already have kidney issues, we reach for the liposomal version.
That makes sense. Before we move off ampho, what about resistance? Does the fungus learn to beat the sledgehammer?
It's surprisingly rare. And that makes perfect sense if you think about the target. Ergosterol is a fundamental building block of the cell.
It can't live without it.
Exactly. For a fungus to become resistant to amphotericin, it essentially has to stop making ergosterol or change it so drastically that the drug won't bind. But ergosterol is vital for their survival. So if they mutate to avoid the drug, they often become very weak and unfit. It's a huge trade-off for them.
It's a high fitness cost. They cripple themselves to evade the drug.
That's the perfect term for it. There are exceptions. Candida lucitaniae and Aspergillus terreus are known to be intrinsically resistant, but generally, if you hit a fungus with ampho, it dies.
Okay, so that's the sledgehammer. It destroys the membrane. But there is another way to win the membrane battle. Instead of destroying the wall, you stop the enemy from building it in the first place.
Enter the azoles.
The azoles. These are the ones everyone has heard of. Fluconazole, ketoconazole.
Right. This is the largest and most widely used class of antifungals. Their strategy is completely different. It's starvation and sabotage. They inhibit a specific enzyme called 14-alpha-sterol demethylase.
14-alpha-sterol demethylase? That's a mouthful. What does it do?
It's a CYP450 enzyme, a cytochrome P450 enzyme, that is responsible for a key step in converting a precursor molecule called linosterol into ergosterol.
So if you block that enzyme, the fungus can't make ergosterol.
Correct, but it's actually a brilliant double whammy. Not only do you run out of ergosterol, which makes the membrane weak and leaky,
Right.
but the precursor molecules, these toxic methylated sterols like linosterol, start to pile up inside the cell. They get shoved into the membrane instead of ergosterol.
And that's bad. Why is that bad?
It's catastrophic for the fungus. Ergosterol is a flat molecule. It packs tightly and neatly, making a strong, stable wall. Linosterol has this bulky methyl group sticking out.
Yeah.
It's like trying to build a brick wall, but using round, lumpy stones mixed in with the bricks.
The wall becomes unstable.
Unstable, the membrane fluidity gets completely messed up, and the membrane proteins that are supposed to be embedded in it stop working properly. Functionality fails. It's fungistatic, not cytal. It stops them from growing.
So the membrane fails from the inside out. Now, the outline mentions there are different types of azoles. It feels like there are a million of them. How do we distinguish them?
We usually split them into two main groups based on their chemical structure. The older imidazoles and the newer triazoles.
Imidazoles versus triazoles, what's the chemical difference?
It's just the number of nitrogen atoms in that azole ring structure. The imidazoles, think ketoconazole, miconazole, clotrimazole,
Yeah.
are the older generation. They have 2 nitrogens in their ring.
And what's the problem with them?
The problem was selectivity. Remember, humans have CYP450 enzymes too, a lot of them. Our liver uses them to metabolize drugs and to synthesize hormones. The imidazoles hit the fungal enzyme, but they also hit our human enzymes pretty hard.
That sounds like a recipe for side effects.
It is. Systemic ketoconazole used to be a standard treatment, but it messed with human steroid synthesis testosterone, cortisol. It caused gynecomastia, which is breast growth in men, menstrual irregularities in women, and even adrenal insufficiency. It was just too messy.
So we don't use it systemically anymore?
Almost never. Today, we mostly relegate the imidazoles to topical use. That tube of cream you buy for athlete's foot or yeast infection, that's usually clotrimazole or miconazole.
Keeping it on the skin keeps it away from the liver and the adrenal glands. Makes sense.
Exactly. But for systemic infections, the deep, dangerous ones, we use the triazoles.
Fluconazole, itraconazole, voriconazole?
Those are the big 3. These have 3 nitrogens in the ring, and that little chemical tweak gave them a much stronger affinity for the fungal enzyme and a weaker affinity for the human one. They're just safer and more powerful.
Let's look at the stars of this triazole group. Let's start with fluconazole. It seems like the most common one.
Fluconazole is the clean sniper. It's incredibly water-soluble. You can take it as a pill, and it gets absorbed almost perfectly. Very high bioavailability. But its real superpower is where it can go.
Distribution.
It penetrates into the cerebrospinal fluid, the CSF, beautifully.
Which is usually really hard for drugs to do. The blood-brain barrier keeps most things out.
Very hard. That makes fluconazole the drug of choice for the consolidation and maintenance therapy in cryptococcal meningitis, a devastating fungal infection of the brain.
And what else?
It's also the go-to for most candida infections, like yeast infections in the blood, candidemia, or on mucosal surfaces like the esophagus. It really is the bread and butter of systemic antifungal therapy.
But it has a blind spot, right? A pretty big one.
A huge one. Fluconazole does not kill molds. It is essentially useless against aspergillus. If you have a patient with invasive aspergillosis mold eating into their lungs, fluconazole will do absolutely nothing.
So if fluconazole is the sniper for yeast, what do we use for the molds?
That's where the newer, broader spectrum triazoles come in. Itraconazole and voriconazole.
Let's talk voriconazole first.
Voriconazole is effectively the drug of choice for invasive aspergillosis. It was a complete game changer. Before voriconazole, if you had invasive aspergillosis, your main option was amphoterrible.
And the prognosis was not good.
Not good at all. Now we have a pill or an IV form that works just as well or even better and is much safer.
But voriconazole has its own weird side effects, doesn't it? I remember reading about vision changes.
Yes, it's very peculiar. About 30% of patients get transient visual disturbances. They report seeing wavy lines, flashing lights, or changes in color perception shortly after taking the dose. It's thought to be an effect on the retina.
Does it go away?
It usually goes away within about 30 minutes, but it can be very disconcerting.
Yeah.
It also causes severe photosensitivity. People can get badly sunburned just walking to their car. And something we're learning more about now. Long-term use is associated with developing squamous cell carcinoma of the skin and also fluoride excess causing bone pain, something called periostitis.
So it's a powerful drug with a quirky and serious toxicity profile.
Very much so.
And what about itraconazole?
Itraconazole is the specialist for a group of fungi called the dimorphic fungi, histoplasma, blastomyces, coccidioids. These are the fungi you pick up from soil or dust in specific parts of the country, like the Ohio River Valley for histo or the Southwest for coccidia.
So it's a niche drug.
A very important niche drug, but clinically, it's a pain to use. Its absorption is notoriously erratic. You need acid in the stomach for the capsules to dissolve, so if the patient is taking heartburn medication like a proton pump inhibitor, the antifungal won't get absorbed. It won't work.
That's a classic board exam question setup right there.
Absolutely. You have to be really careful about how it's administered.
Okay, so we have the sledgehammer, AMPHO, and the membrane saboteurs, azoles. But there is a giant caution sign flashing in the outline regarding azoles. It says, the drug interaction minefield.
This is critical.
Yeah.
If you take nothing else away from the azoles section, remember this. Azoles are CYP450 inhibitors. That is their mechanism of action. That is how they kill the fungus.
Right.
But they also inhibit human CYP450 enzymes in the liver to varying degrees.
And the liver uses CYP450 to break down dozens of other drugs.
Exactly. It's the body's garbage disposal system for pharmaceuticals. So imagine a transplant patient. They're on cyclosporine or tacrolimus to prevent rejection of their new kidney. Those drugs have a very narrow therapeutic window.
Meaning too little and you reject the organ, too much and it's toxic.
Precisely. The liver is constantly chewing up those drugs to keep the levels in that safe zone. Now, if you throw in an azole to treat a fungal infection, you jam the radar. You block the disposal system.
So the levels of cyclosporine start to rise.
They don't just rise, they can skyrocket. Suddenly your patient is in acute renal failure from toxic levels of cyclosporine just because you gave them some voriconazole. Or if they're on the blood thinner warfarin, their blood gets way too thin and they can have a major bleed.
So managing azole therapy is 50% treating the fungus and 50% managing the patient's other medications.
That's a great way to put it. It requires constant vigilance, therapeutic drug monitoring, and dose adjustments. It is not a simple prescription to write.
Okay. Before we leave the membrane entirely, there is one more drug class mentioned, the elamines, and specifically a drug called terbinafine.
Ah, yes, terbinafine. You probably know by its brand name, Lamisil.
The toenail fungus commercial, I remember the little cartoon creature digging under the nail.
That's the one.
Yeah.
And medically, that cartoon is surprisingly accurate. Terbinafine has a very specific niche. It also blocks ergosterol synthesis, but it hits a different enzyme even further upstream from the azoles. It inhibits squalene epoxidase.
Squalene epoxidase.
By blocking this, not only do you stop ergosterol production down the line, but a precursor called squalene accumulates inside the cell, and squalene itself is highly toxic to the fungus.
So another double whammy.
Another one. But the really cool thing about terbinafine is its pharmacokinetics. It is highly keratophilic.
It loves keratin.
It loves keratin. When you take a pill of terbinafine, it distributes all over the body, but it has a massive affinity for and concentrates in the skin, the fat, and specifically the nail beds. It gets incorporated into the growing nail plate.
And it stays there.
It stays there for weeks or even months after you stop taking the drug, providing ongoing protection.
Which is perfect for a nail infection because nails grow so slowly, you need that long-term presence.
Exactly. It's the undisputed king of onychomycosis, or fungal nail infections. But you rarely see it used for deep systemic infections. It's a skin and nail specialist.
Okay, so that wraps up Battlefield 1, the membrane. We have ripped it apart with AMPHO. We've stopped it from being built with azoles and terbinafine. Now, let's move to Battlefield 2, the cell wall.
Yummer.
The outline calls this a safer target. Why is the cell wall safer than the membrane?
This goes back to Biology 101. Human cells have membranes. Fungal cells have membranes, but fungal cells also have a rigid cell wall outside their membrane, made of complex sugars like glucans and chitin.
And human cells?
Do not have a cell wall. We don't have one at all.
Zero.
Zero. So if you can design a drug that targets the cell wall, you are targeting a structure that literally does not exist in the human body. The potential for selective toxicity is enormous.
This sounds like the penicillin concept. Penicillin targets bacterial cell walls, which humans don't have, so it's incredibly safe for us.
Exactly. This was the holy grail of antifungal research for a long time, finding the penicillin of antifungals. And the drugs that finally achieve this are called the echinocandins.
The echinocandins, caspofungin, mycofungin, and edulafungin.
Those are the three.
So how do they work? What's the target?
They target a specific enzyme called β-1/3-glucan synthase.
Okay, unpack that name for me.
Think of the fungal cell wall like a reinforced concrete wall. The beta-glucan strands are the steel rebar, the crossbeams, that link together to give the wall its structural integrity.
Okay.
The beta-1/3-glucan synthase enzyme is the blacksmith forging and knitting those rings of rebar together.
Yep.
The echinocandins come in and handcuff the blacksmith.
So the armor doesn't get knit together properly. The rebar is missing.
Right. And without that rigid armor, the fungal cell is just a soft, fragile balloon. The osmotic pressure inside the cell builds up, water rushes in, and because the wall is weak, the cell just bursts. It undergoes osmotic lysis.
And because humans don't have this enzyme or this wall,
The side effects are minimal. Compared to amphoterrible, the echinocandins are incredibly well tolerated. Maybe some minor GI upset, a little bit of flushing due to histamine release during the infusion, but no kidney failure, no shake and bake, no bone marrow suppression. They're very clean drugs.
that sounds perfect. Why aren't they the only thing we use? There must be a catch.
There are a couple of catches: spectrum and delivery. First, they are large molecules. They are lipopeptides. You can't absorb them from your gut. They have to be given IV,
So no pills.
no pills, which means you can't send a patient home with a bottle of caspofungin. It's an inpatient, hospital-only drug. That's a major limitation for long-term or outpatient care.
Okay. And the second catch, the spectrum.
Right. Their spectrum is specific. They're fungicidal. They're killers against most Candida species. In fact, they kill even the azole-resistant Candida strains like Candida glabrata. So for a really sick patient with a yeast infection in the blood, they are fantastic.
Got it.
Against Aspergillus, the mold, they're only fungistatic. They stun it, they damage the tips of the growing hyphae, but they don't necessarily kill it outright. And they have a few big holes in their coverage.
Such as?
They are completely useless against Cryptococcus.
Why? I thought Cryptococcus has a cell wall, doesn't it?
It does. But Cryptococcus is sneaky. It hides its cell wall behind a thick polysaccharide capsule. It's like wearing a big, thick cloak over your suit of armor. The drug just can't reach the target effectively. There are also some structural differences in its glucan synthase that make it less susceptible.
Ah, clever. So echinocandins are safe and powerful, but mostly for Candida and sometimes as a second-line agent for Aspergillus.
Correct. Clinically, you can think of them as the rescue squad or the safe bet for candidemia in the ICU. If a patient is crashing and you don't know what Candida species it is, or if you're worried about resistance or kill, it opens the door and welcomes it in, thinking it's food. Once inside, another exclusively fungal enzyme cytosine deaminase gets to work. It converts the harmless 5-FC into a molecule called 5-fluorosil, or 5-FU.
Wait, 5-FU? I know that name. That's a chemotherapy drug used for colon cancer and other solid tumors.
It is a potent cancer chemotherapy agent. It's an absolute bomb for a cell. It gets converted into metabolites that do two things. One, inhibits an enzyme called the midylate synthase, which shuts down DNA synthesis, and the other gets incorporated into RNA, creating nonsense proteins. It completely halts cell division and protein synthesis.
So the fungus brings in this harmless molecule, converts it into a deadly chemotherapy bomb inside its own kitchen, and blows itself up from the inside.
That is the Trojan horse, a perfect example of suicide inhibition.
That is brilliant. But if it converts to 5-FU, isn't that dangerous for the human too? I mean, 5-FU is highly toxic.
It is. And that's the downside.
Yeah.
Ideally, this conversion only happens inside the fungus because we lack cytosine deaminase. But our own intestinal flora, the bacteria in our gut, can sometimes perform this conversion. And human cells can sometimes take up a little bit of the drug.
So some of it does become 5-FU in our bodies.
A little bit. And so you do see chemotherapy-like side effects in the patient.
Like what? What should we watch for?
Bone marrow suppression, leukopenia, which is low white blood cells, thrombocytopenia, which is low platelets. Basically, it starts to poison our own rapidly dividing cells in the bone marrow. It can also be toxic to the liver.
So it's a toxic drug.
It has significant toxicity, yes. You have to monitor blood counts and drug levels very closely. But the biggest problem with flucytosine isn't even the toxicity, it's resistance.
The fungus learns the trick.
Unbelievably fast. Think about the chain of events. Entry via permes, conversion via deaminase.
Yeah.
If the fungus develops a single point mutation in either of those enzymes, if it just deletes the gene for the permes, it becomes completely resistant.
It just locks the door and the Trojan horse can't get in.
Exactly. Or it breaks the activation machinery.
If you give flucytosine by itself, resistance can develop within days, even during a single course of therapy. That is why the golden rule of flucytosine is never use it alone.
It's always a wingman. It's a combination drug.
Always. We almost exclusively use it in combination with amphotericin B.
Why that combination specifically? What's the synergy there?
It's beautiful synergy. Think about it. Amphotericin B punches holes in the membrane.
Right.
Flucytosine needs to get inside the cell to work. The Ampho-B holds the door open, or more accurately, smashes the wall down, so the flucytosine can rush in at much higher concentrations and bomb the nucleus.
That is a devastating 1-2 punch.
And it's the standard of care for the induction phase of treating cryptococcal meningitis. You need that heavy, rapid, synergistic hit to clear the infection from the brain as quickly as possible. So we have surveyed the entire arsenal. We have the sledgehammer, Ampho, the builders, azoles, the armor breakers, echinocandins, and the Trojan horse, flucytosine. Now, we need to put on our white coats. How does a clinician actually use these? The outline talks about clinical integration and proportionality.
This is the art of medicine. It's not just knowing the drugs, it's knowing when to use which one. You have a patient in front of you. Which drug do you choose? It all comes down to a balance. Severity of illness versus toxicity of drug.
Let's run through the scenarios from the outline. Scenario 1. Superficial infection, ringworm on the arm, or a simple vaginal yeast infection.
Low severity. The patient is not going to die from this. So you have zero tolerance for toxicity. You are not going to risk kidney failure with Ampho or major drug interactions with voriconazole for a simple rash.
So you use topicals, keep it local?
Exactly. Topical azoles like clotrimazole cream or nystatin. Nystatin is a polyene. It works just like Ampho, but it's way too toxic to ever inject. However, it's not absorbed from the gut or skin, so we can safely use it as a swish and swallow for oral thrush or as a cream. You keep the drug where the fungus is.
Okay. Scenario 2. Systemic but stable. This is a patient who maybe has HIV and has esophageal candidiasis thrush going down the throat, but their blood pressure is fine. They are in shock.
Here, the infection is deeper, so creams won't work. You need systemic power. But you still want safety and convenience. You reach for fluconazole.
The sniper.
The sniper. It's oral, it's safe, it works. You can send them home with a prescription. It's the perfect choice for that situation.
Scenario 3. The crash. This is the nightmare scenario. A patient in the ICU. Septic shock. Fever despite broad-spectrum antibiotics. Multi-organ failure. You suspect a fungal bloodstream infection.
In a crash, you don't have time to be subtle. You don't have time to wait for cultures. You need to kill the fungus now or the patient dies. You bring out the heavy hitters. You have to assume the worst.
So amphotericin B or an echinocandin?
Exactly. You start with IV liposomal amphotericin B for its broad spectrum, or an IV echinocandin like caspofungin for its safety and excellent candida coverage. You hit hard and you hit fast. You want broad coverage because you don't know if it's a resistant yeast or a deadly mold.
And then what? You don't keep them on that forever?
No. Then once the patient stabilizes and the cultures come back identifying the specific bug and its susceptibilities, you de-escalate. You switch them to a targeted oral azole like fluconazole or voriconazole to finish the course. You don't keep them on the toxic and expensive IV drug any longer than you have to.
Okay, final scenario, number 4. The CNS sanctuary. Fungal meningitis.
This is one of the trickiest situations because the brain is a fortress. The blood-brain barrier is designed to keep things out, including our drugs. The echinocandins, they are huge molecules. They do not cross the blood-brain barrier.
So you cannot use caspofungin for meningitis?
Absolutely not. It simply will not reach the infection.
So what do you use?
You have to use drugs that penetrate. Fluconazole gets in beautifully. Flucytosine gets in. And amphotericin B, surprisingly, Ampho-B itself doesn't actually get into the spinal fluid that well. But because it is so potent, and because it can access the inflamed meninges, the lining of the brain, it is still the drug of choice for the induction phase.
The classic cryptococcal regimen, Ampho-B plus flucytosine.
Exactly. Punch the holes, send in the bomb, clear the infection from the CSF as fast as possible. Then, once the CSF is sterile, you de-escalate and switch to high-dose fluconazole for long-term maintenance therapy, sometimes for life.
It really is a strategic game. You have to know your enemy, know your weapon, and know your battleground, specific tissue you're trying to treat.
And you have to know your patient's physiology. Are their kidneys already failing? You could probably lean towards the echinocandins or a liposomal ampho. Is their liver failing? You have to be incredibly careful with the azoles.
So, to zoom out, what does this all mean? We've covered a lot of ground.
If we zoom all the way out, I think the big takeaway is that antifungal therapy is the pharmacology of narrow discrimination. We are exploiting tiny, subtle, eukaryotic nuances.
The ergosterol versus cholesterol difference.
Right.
The presence of a cell wall that we lack. The cytosine transporter that the fungus has and we don't.
Exactly. And because those differences are so small, the therapeutic window is often very small. We're always balancing on a nice edge between curing the infection and hurting the host.
And looking at the future, the outline ends with this provocative thought, the evolutionary arms race. This isn't a static field.
Not at all. This is the worry that keeps infectious disease doctors up at night. Just like bacteria are becoming resistant to our best antibiotics, fungi are adapting. We are seeing the rise of species like Candida auris.
I've seen the headlines about that, the superbug fungus.
It is a superbug. It's a multi-drug resistant yeast that spreads in hospitals and long-term care facilities. Some strains are resistant to azoles, to amphotericin, and to echinocandins. It's resistant to all three major classes of drugs we have.
That is absolutely terrifying. If we lose these three targets.
We don't have a fourth battlefield yet. There are very few new antifungal classes in the pipeline. And that's why stewardship is so important. We can't just throw broad-spectrum antifungals at every unexplained fever. We have to be precise. We have to be thoughtful. We have to protect the precious few weapons we have.
Keep your membranes stable and your walls strong.
That's the motto.
Well, this has been a true deep dive. For those of you listening, if you want to see the molecular diagrams of that sponge model versus the pore model, which I highly recommend, it makes it click. Open up Goodman and Gilman, Chapter 61.
It's a great visual.
And for the clinical dosing tables and that huge, scary list of azole-drug interactions, check out Katsung, Chapter 48.
The diagrams really help visualize the concepts. It's worth a look after listening to this.
Absolutely. Thank you for listening. Stay curious, and we'll see you on the next deep dive.
Goodbye, everyone.